My name's Dr. Claire Ellender. I'm a respiratory and sleep physician at the Princess Alexandra Hospital in Brisbane. And I work with my colleagues in the pulmonary hypertension unit. It's a pleasure to be able to talk through around some of the issues around monitoring and measurements of PAH. I think one of the things to think about is really about the symptoms of pulmonary hypertension before we kind of delve into that monitoring and maintenance, because this formulates a lot of what your doctors and teams will be keeping an eye out when they see you initially in clinic with suspected pulmonary arterial hypertension, PAH, or in the ongoing management. So you can see things around dyspnea, fatigue, exercise limitation. They're some of the really important symptoms that your team will be asking about initially. How do we monitor and measure PAH treatment success? A lot of things comes to the functional class. So in each clinic visit, your doctors will be asking questions around exercise limitation, breathlessness, to come up with a New York Heart Association functional class, also known as a WHO functional class. And you can see here that we will document this between 1 and 4, 1 being people who have minimal limitation and 4 being people who are really struggling with severe symptoms of PAH. So the kind of questions that I ask in clinic is around, are you getting breathless, walking up a hill, getting dressed, doing activities of daily living like making the bed, having a shower, and that helps guide your doctors and your team to understand how bad your symptoms are. These symptoms we then combine with a number of measured tests. So no doubt many of you who come to see us in the pulmonary hypertension clinic will be feeling poked and prodded from all of the tests. And that's because the international guidelines recommend that we do these tests at baseline, and then some slightly different tests, as I'll show you in a minute on a slide, at every 3 to 6 months. So what this complicated table is showing is that your doctors at baseline will be looking to understand how your pulmonary hypertension is affecting you, and to get an idea about whether at baseline, when you're first diagnosed, is your PAH in a low risk side of things, an intermediate risk, or a high risk. And people who are in high risk are going to need more urgent, faster, bigger, more robust treatments, whereas people in low risk can have less intensive therapy, maybe fewer medications potentially, and their follow-up could be stretched a little bit. So what I'm showing you here is that your doctors will be looking through and having a look to see if you've got signs of heart failure. The 6-minute walk distance, that's where you're walking up and down the corridor for us before clinic. And for most people, we're hoping that their disease is in the range where they can walk more than 440 minutes at baseline. That number I like to see even higher, above 550 for young people, so it is age defined. So CPET is a cardiopulmonary exercise test. In Australia, this test is not as widely used. We tend to use a combination of echocardiogram, that's the ultrasound you have on your heart at baseline, and a blood test, the BNP, or brain natriuretic peptide. BNP is a sign of stretch and strain on your heart. The more stretch and strain there is, the higher the blood test will be, and the more strain there is on the heart. So long story short, you can see that at baseline, your team is putting together a combination of how you're feeling, how far you can walk, what your blood test looks like, what the ultrasound on your heart looks like, and those findings on that right heart catheter test that you had at baseline, to get an idea if you're in low risk, intermediate risk, or high risk. And they will custom your treatment at baseline to make sure that you're getting enough treatment for your disease, but not risking side effects by over-treating. So that's baseline. And then you feel like you just got your head around everything, and then boom, we've got you back into clinic 3 or 6 months later, depending on where you were at baseline. And we're doing a smaller number, but similar tests at that mark. And we use that then to re-stratify people into low risk, intermediate low, intermediate, high, and high risk, and again adjust treatment based on those things. So it's a shorter version of what we were doing before. It's how you're feeling with the WHO functional class, so down the left-hand side, how far you're walking, and what the BNP blood test was like. And so the reason for dividing these up then into a few more groups is to even, again, tweak your medications at that 3 or 6 month mark, depending on how things are going. How often should we be doing these tests? Really, that's for most people, initially more follow-up 3 and 6 months for the first couple of years, and then things can kind of space out depending on how things are going after that. And there's some, again, in these international guidelines, your clinicians have got this table that really helps guide about when to do more invasive tests, like a right heart cath. So you can see down the left-hand side, right heart cath down the bottom there, it's really recommended at baseline. So that's where the green one, everyone should be getting a right heart cath at baseline unless there's a really big contraindication. And there's yellow indicates some evidence in favour of certainly repeating a right heart cath if things get any worse. And many centres will repeat a right heart cath 6 months after any changes to therapy, just to make sure you're on track. It's really great for as many experts to be involved in your care as you can, to kind of get different people's perspectives. So your GP really needs to be the centre point for coordinating all your care and making sure that things like your routine blood tests are getting looked after, that monitoring. So most of the medications that we will need to prescribe for PAH need some monitoring of liver function, and many people will need to be on diuretics or will need to have their kidney function checked every 3 to 6 months. So I think from that side of things, I would recommend that the majority of people have an appointment with their GP every 3 to 6 months as an absolute minimum. With regards to prescribing your PAH medications, doctors do need to have expertise and some specialist training to be considered an expert in PAH treatment. And that will usually be a respiratory doctor, a lung specialist, respiratory physician, or a cardiologist, a heart specialist, or sometimes a combination of the two in teams. And so you'll need to be seeing those specialists every 6 months as a minimum to be getting your prescriptions through the pharmaceutical benefits scheme. I then think it's really amazing if you can get linked into your local community pulmonary services. And I know the Lung Foundation will probably have some links that we can put in here to get a feeling for where that local service is. And it's a matter of being linked in with some allied health professionals, particularly physiotherapists and exercise physiologists, to see what kind of specialist exercise programs might be safe and appropriate for you. For people with really severe pulmonary arterial hypertension, I'd really recommend you talk to your specialist team about where is the best place for you to be doing exercise, how to make sure it's done safely, and who can supervise that, because there are some provisions around exercise in PAH, but we do know from big studies that there are some benefits for overall health in terms of how your PAH goes and how you feel by doing some exercise. But I think just make sure you've got some people to make sure you're doing it safely. And I guess the last thing just to comment on, which is certainly not to saying it last, but it's not the least, is that having any chronic disease, but particularly such as a big impactful one such as PAH, has a lot of toll on our mental and psychological health, as well as our physical health. So I think if you can, a combination of your GP, patient support groups, and maybe even seeing if there's a psychologist or counsellor in your local area that you can be linked in, would be worthwhile. If you're getting to the point where this is playing on the mind and you're feeling blue or feeling low with this, then booking in to see your GP, and there's things like mental health care plans that can help with the cost of accessing psychology visits. that would be something that I think is really important, because when our physical health is low, our mental health can be low. And when our mental health is low, then our physical health can be low. So, we wouldn't just go and change the oil when we had a flat tire. We would need to do both if we were looking after a car properly. And we're just complex engines at the end of the day. So I recommend doing both together if that's something that's important for you. There's some really important warning signs with PAH to let your GP know at any of your regular visits, and certainly your specialist team. And if you are in an area where you're fortunate enough to have a pulmonary hypertension nurse or nurse consultant that you have the ability to ring up and let know, that's a really important service to be aware of, and ask when you get your diagnosis, is there a number that I can call in working hours if I am worried? So the sorts of things that I would definitely want to know about would be if things are rapidly changing. So if breathlessness is getting really worse over a week or so, I would want you to book in to see your GP. Obviously, if things are really rapidly worse, there's an ambulance and a hospital service for really, diabolical things. But if your breathlessness is changing over the week, your fluid is becoming a problem, so weight going up, ankles getting swollen, can't lie flat at night time, that's something that if it was kind of creeping up, I would love my patients to ring my nurse consultant and to let me know, and then we can problem solve around. Definitely chest pain that's on exertion, that's associated with any kind of extension into the jaw or down the arm, that's an ambulance. But chest pain that's kind of grumbling along in the background without another explanation, that's something to let us know about. Certainly, so there's this thing called syncope. Syncope is where we have blackouts, or pre-syncope is where we kind of get groggy or lightheaded, a bit woozy when we stand up. That's something that I want to know about. And anything where it's signs that the heart might not be keeping up with the requirements of the body. So low blood pressure, poor circulation that's out of the ordinary, and definitely any palpitations or something that might suggest an arrhythmia, a funny heart rhythm has occurred. So I think the key message here is those warning signs, things changing quickly, signs of heart failure, so swollen ankles, can't lie flat, blackouts or near blackouts, low blood pressure, palpitations, funny heart rhythm. Those 5 would be worrying. If it's stuff that's changed really quickly, that's an ambulance. If it's stuff that's kind of grumbling in the background, that's a talk to your nurse consultant for your unit. The advantage of a pulmonary hypertension expert referral centre is that you've kind of got the whole team there who are working together, making sure that we have the services and the infrastructure necessary to meet all of those international goals. We spoke about earlier about all those many tests that are required. That's something that needs a big team behind it in order to be able to deliver those sorts of tests and those sorts of assessments at a really high quality. Also at one of the expert centres, you're very much more likely to have a nurse consultant. And I mentioned earlier how great it is to be able to contact them early in the piece if things aren't quite right, rather than waiting for it to be a big emergency and needed to come into the emergency department. Definitely trying to pick things up earlier means that we can be faster and more effective with our treatment.